Hello, my name is Dr. Jeff Calvert. I am the Associate Director for Clinical Quality at the World Trade Center Health Program, which I'm sure you know is part of NIOSH and CDC. It's my privilege to introduce today's webinar, which is titled Artificial Intelligence Diagnostics for World Trade Center Related Post-Traumatic Stress Disorder, or PTSD. As you know, artificial intelligence, or AI, has been a recent focus of media attention. By leveraging large amounts of data, AI can identify patterns and relationships and use that information to make predictions. It can also generate human-like outputs. So AI has much potential and much promise. But with so much potential and promise, is AI something to embrace or something to fear? Will it augment human output or replace humans? Perhaps today's webinar will help provide that answer. So I've read that now is the time to engage with AI, because AI is rapidly advancing. Those who delay such engagement will be at a disadvantage in the future. So by attending today's webinar, it appears you also recognize the importance of engaging with AI now. So today's webinar is very relevant. It'll be delivered by 3 speakers, as you heard: Dr. Roman Kotov, Dr. H. Andrew Schwartz, and Ms. Whitney Ringwald. Dr. Kotov is a licensed psychologist. He received his PhD from the University of Iowa and is a full professor in the Psychiatry department at Stony Brook University. He is also the director of Translational and Clinical Epidemiology, which is a research division. He also directs mental health services at the Long Island Health Program for the World Trade Center responders. And he's published over 250 papers. Finally, he is the founder and lead of the Consortium for Hierarchical Taxonomy of Psychopathology. Next, moving to Dr. Schwartz, he's the director of the Human Language Analysis Beings Interdisciplinary Lab, also located at Stony Brook University. He received his PhD in computer science from the University of Central Florida. He has co-founded the World Wellbeing Project, which is a consortium involving researchers from the University of Pennsylvania, Stony Brook University, and Stanford University. Finally, he was a recipient of a 2020 DARPA Young Faculty Award. And finally, Ms. Ringwald is completing her doctorate in clinical psychology at the University of Pittsburgh. In her research, she uses digital technologies to advance how mental illness is assessed, diagnosed, and treated. And I find it impressive that she is already, in her relatively young career, has published over 30 peer-reviewed papers. So today's talk promises to be extremely interesting and enlightening. So without further ado, I present Drs. Kotov, Schwartz, and Ms. Ringwald, who will share their findings on using artificial intelligence to improve diagnostics for World Trade Center related PTSD. Take it away.
Okay, so we should be looking at Roman's screen. If you're not seeing that, you may need to click on the switch to shared content on your screens. And this work we're going to talk about today is part of the PTSD STOP project, which is a multidisciplinary team across computer science, psychology, and psychiatry. On the investigator side is, of course, Roman Kotov, that you already met. Actually, we're not listed on this slide since we're presenting, but we've also got and Whitney's on that team as well. But we've also got these other folks here: Oscar Schell, actually from Lund University, psychology, and works on, as we'll talk about, some of the state-of-the-art language-based assessments of mental health. Ryan Boyd, who is a psychologist by training, but sits with me as part of the Human Language Analysis Lab. Dimitris Samaras is a vision expert, and Benjamin Luft, who directs the World Trade Center Wellness Program at Stony Brook University. And so we've been working together with a good team of graduate students who are doing some of this work as part of their PhD and other projects. Scott Feltman, Adi Ganesan, and Alfredo Rivera, implementing a lot of the techniques we're going to talk about, and a big team of staff: Jonah, Kayla, Kevin, and Chris, who are helping to interact with our participants. We have quite a large recruitment effort going on. And so our talk today, we will first go through the motivation for this line of work on using artificial intelligence to better understand PTSD, symptomatology, and diagnostics ultimately. We'll talk about the prior work and what we've done so far on how these AI techniques can be applied to mental health and PTSD assessment. Then we'll talk about some incremental validity of some of our strongest language-based assessment models. Whitney we'll be talking about that, as well as understanding the role of emotions. Getting into one of the things we're pushing AI to be used better for is longitudinal assessment of people across time, and some of our earliest work on the dynamics of PTSD and emotions from such longitudinal data. And then finally, we'll end with implications. And so Roman's going to take over from here and talk us through the motivation.
Thank you, Angie. As you see, this is an unusual webinar in that it's a tag team approach. I hope we orchestrated it well and the dance will go smoothly. Bear with us. So the clinical impetus for this project and this whole line of work, frankly, is that PTSD is a very tough clinical condition. About 20% of people exposed to trauma develop symptoms that are either chronic or have delayed onset. Not all of them meet criteria officially for PTSD diagnosis, but just about all of this 20% have clinically significant symptoms. Now, just talking about people with PTSD diagnosis, 50% remit relatively quickly, but the other 50% have a chronic variant that is continues on typically for years. We do have medications, but they are suboptimal, to say the least. For example, the only medications that FDA approved for PTSD, serotonin reuptake inhibitors, do work in comparison to placebo, but the difference on average between them is just 23% of a standard deviation, a small effect in terms of symptom improvement. Then psychotherapy is more efficacious, but and then roughly a third achieve some degree of remission with psychotherapy, but 2/3 do not. We cannot predict for a given patient which category they're in or what's to expect, and that's a broader problem with existing PTSD diagnostics. They're not good at predicting outcome for a given patient, so you can give them their prognosis. Diagnosis doesn't actually do that in psychiatry. The treatment response as to what treatment this particular patient needs, we can't even tell whether they will benefit most from psychotherapy or from medication generally, let alone how to go about delivering treatment. Unfortunately, a case can be made that PTSD is also a poor guide to science. Just to give one illustration, there are currently no drugs for PTSD in a pipeline. Nothing specifically being developed for this condition. Hard to know exactly why PTSD is facing such challenges, but there are two potential explanations. One is that diagnosis is entirely reliant on report of the patient, whether you're using PTSD checklists, as all monitoring programs involving monitoring component do, or you give a clinician diagnosis using instrument like the SCID or DIS. It ultimately comes down to how the patient describes the experiences. And we don't, unlike pretty much the rest of medicine, we don't have any biomarkers. We do not have cell cultures. We do not have blood panels, just patient report. The other problem is that PTSD is extremely heterogeneous. It is, in fact, the most heterogeneous of all mental disorders. And we can reduce this heterogeneity somewhat to 4 fundamental dimensions of symptoms, also sometimes referred to as clusters. But in addition to that, we also have a complex interplay between symptoms over time. And diagnostics is completely such as DSM, our diagnostic manual, is completely silent about these complexities. Diagnostic manual includes a delayed expression specifier, and that's it as to how to capture these intricate patterns. So it doesn't. So let me talk about the second problem for a moment. So a possible solution to it are personalized models. That is a computational model fit to behavior of this given person, given patient, perhaps over time. And so by analyzing this statistically, as opposed to a qualitative judgment of a clinician, we can precisely identify which symptoms are relevant for this patient, that is, which are they prone to experiencing, which ones are not, what is the sequence of symptoms. Symptoms often form cascades, with one problem emerging first, leading to the second, to the third, and escalating to full-blown episode. We can identify for the patient what is typically the trigger for them. It's both symptom triggers and also environmental experiences, such as seeing a movie that reminds them, for example, of 9/11. For other person, it may be smelling the smoke that is somewhat reminiscent of fires at ground zero. For others, it may be stress, but it is possible to incorporate these environmental factors into our statistical models, computational models, as well as response to treatment, like when the person is on or off treatment, on psychotherapy, let's say CBT versus exposure therapy, what is the response? So once such model is estimated, it can guide provision of individualized care. It also can tell us in real time when the person is at particular risk, the cascade is about to go off, and that's an opportunity to intervene in real time using smartphones in every pocket these days. And a smartphone can deliver specific intervention, let's say exercises, basic elements of psychotherapy tailored to this particular person, or it could be a clinician giving them a phone call. But in any case, this is all contingent to do this strategies in a way that's smart, intelligent, on building these computational models. The other problem I mentioned is of a lack of objective markers. And you'll hear today us talking a lot about behavioral markers. My apologies for the background. There's a fire alarm in my office. Hopefully it won't require me to leave. Okay. It's just going to go off in the background for a moment. I do not have to go anywhere. So, why behavior markers? Why is that our focus today? Well, biomarkers is what where psychiatry turned to as soon as it was technically possible. And for the last 30 years, even more, we have been pursuing neuroimaging, molecular signatures, and lots of data has accumulated. And I think the picture is clear. I will illustrate this with just a few examples, but hopefully they'll give you a sense of the literature overall. So fMRI, functional neuroimaging, has been conducted for hundreds of studies with PTSD, and meta-analysis have been done to aggregate findings of the studies. And this particular website, Neurosynth, presents you with results using meta-analytic techniques. And so what you're looking for is a hotspot, like bright red. This is where consistently associations are found between neural activity or lack of it in that region and the condition. For example, for Alzheimer's on the left, there's a clear bright spot in the temporal lobe, just as you'd expect. We don't have that for PTSD. The smattering of non-significant results. Yes, individual studies have results. They're just not in the same region. And so, in other words, lack of replication. Of course, meta-analysis have the flaws. The victims basically, or they're dependent on quality of primary literature. So the better strategy is to collect a lot of data from different studies and do mega-analysis. That is, reanalyze all the raw data in a consistent way and have big sample size to answer the question. which is what this consortium has done. This consortium is Enigma. They aggregated neuroimaging from 3,000 participants, half of whom had PTSD. And they found, looking at white matter alterations, that the region that is most discriminant, that discriminates the best between cases and non-cases of PTSD, explains for less than a third of 1% of variance in PTSD risk. And that's the strongest region. All the rest of them are weaker. Same finding also from Enigma for cortical volume. In short, so far, we have lots of small studies that are promising. Large studies did not bear this out. They found the effects to be meaninglessly small. I mean, certainly too small for clinical use. We do have one biomarker. In my opinion, we have one. This is polygenic risk score. About 4 years ago, we finally got one for PTSD that works. It has been replicated again and again. Let me just show result in World Trade Center responders, since most relevant to our audience. And we've done this in the sample of nearly 6,000 responders, where we plotted their trajectories, the individual trajectories over 2 decades, and predicted them using polygenic risk scores. And here you have standardized regression coefficients, betas. They're basically correlations, same metric. And so this polygenic risk score for PTSD correlates 0.17 with the starting value of a trajectory, starting point of the trajectory, and another 0.12 independently with the slope of the trajectory. So this graph sort of puts this in the context. So at the x-axis, you have years since 9/11. On the y-axis, you have PCL score expressed on standardized metric. So the purple line at the bottom is the person, typical person with very low polygenic risk. And in the hot red at the top, or hot pink, I suppose, is the person typical of very high level of polygenic risk score. And so you see that the two trajectories clearly diverge. The most they diverge is about 0.3, z-score of 0.3. That is by about a third of a standard deviation. And everyone else, all other trajectories are closer together. So in other words, yes, it's replicable, but it is still weak and doesn't explain all that much. This is where we come to Andy Schwartz and a potential that behavioral assessments have to offer, unlike our current biomarkers.
Great, thanks, Roman. All right, so you should be seeing my screen now with the same slide. So yeah, this is AI-based assessment. So where the idea is we observe behavior, particularly focused on communication behavior, similar to, a clinician working with a patient, except we use AI models to be able to get a concrete quantified number or set of scores, ideally, that characterize the patient's symptoms, risk potential, and other factors related to PTSD severity. So in preliminary work, we've found that, and others, that based on interviews, applying pre-existing AI models on hour-long interviews, we were able to get associations with separately assessed PCL scores that these models were not even aware of, with correlations above 0.3. So showing some promise in this area. Now, the thing is, these models were developed primarily, a lot of the AI for mental health work has focused a lot on text-based and social media type messaging, the idea of observing people in their ecologically. But of course, many responders from the World Trade Center cohort that are not necessarily that active in social media domains. There's also privacy concerns. And so in this case, we're interested in something that can be embedded into a clinical practice, into an interview, basically. And so the preliminary work used models that were not developed for that situation and yet still got these decently strong convergence with PCL scores. Further, getting at more fine-grained symptoms, there are models that already exist across more than just language. For example, nonverbal communication or facial expressions that capture dimensions of hyperarousal, numbing, and avoidance. Same with speech. And language, pre-existing models from language also capture those dimensions, as well as dimensions of re-experiencing. And so the issue, though, with these current models is they've mostly been developed cross-sectionally, just distinguishing between people, but not necessarily saying things about the future. There are no established multimodal detectors that are combining visual, audio, and language-based signals. And then in more generally, we need more accurate and generalizable models. We'll talk a little bit about some of the AI models in other domains that haven't generalized quite as well. And so our project is PTSD STOP. I think Roman came up with this nice acronym, Symptom Tracer and Outcome Prognosticator, where the overarching goal is develop AI-based communication assessment of current symptoms and future outcomes. And doing this using the three modalities of data, video, audio, and language, which we're acquiring from participants who are doing daily interviews. And this is assessed then with new models. We're getting this data at sizes that we're actually able to make models specific to PTSD, and not just that, but the 4 symptom domains that Roman first introduced: hyperarousal, numbing, avoidance, and re-experiencing, as well as what we call open vocabulary behavioral markers, or more data-driven markers that emerge from these signals. We have three aims. The first one is to develop these models concurrently. And so the idea is taking models that were more meant for other domains and bringing them to the interview domain and multimodal domain. And we're going to present some exciting results we have for thus far for such a setup. And aim 2 is focused more on longitudinal prognosis, where we're trying to understand longitudinal dynamics and what's someone's risk in the future for developing more symptoms, or more specifically, maybe what sort of treatments might be most appropriate for them. And then finally, in aim 3, we're excited to be, I'm going to talk about some of the things we're already doing to test the generalizability of these models, but what we've proposed here is actually to take the model to a completely new patient population. We're doing prospective studies already, but this would be the first time such models are tested for generalization to a new patient population in a systematic manner. In a way, our preliminary work did some of that by taking models from another cohort and other sorts of data to this domain, but this now would allow it in a more systematic manner and to really understand how accurate these AI models can be in new situations. So just to get an idea of this previous work and understanding how these models can help across time, we looked at AI models of anxiety, depression, and emotional stability, and extroversion in hour-long interviews, and then looked at the trajectory of PCL scores over 2 years after that date. And what we found was, well, first, all of them had associations in the theoretically meaningful direction. And importantly, the anxiety model, again, that's focused on assessing anxiety at the date of the assessment, had a significant association, even adjusting for age, gender, occupation, and years since 9/11. And it's a trajectory prediction, so it's also controlling for the PCL score at the interview date. So saying, predicting whether one's symptoms were likely to get better or worse going into the future. But again, that was on a limited sample, and these data were not well aligned with this this domain. And also, there's been recent concern with the generalizability of clinical prediction models. And so as we've been setting up our PTSD stop AI models, we also developed a sort of adaptation of the traditional pre-registration approach, which we call sequential evaluation with model pre-registration. So rather than just pre-registering hypotheses before they're tested to a later date, this approach takes an AI model that's developed. Are you able to see my mouse actually? Is that, yes.
Yes, I can.
Okay. So we take, you know, a set of training data, okay, where we have participants collected at one point in time, and then we draw a boundary, and everyone after that date is not included in the data. In this case, it was, I believe, August 2022. And we just develop our model using people in this, what we call training and development data. And an important thing for developing these AI models is that there is some kind of functional loop going on, but that's also why it's important we keep aside a set of data that we don't even touch. And it's also the nice thing is if it's prospective, you know, simulating an existing model being applied to people entering the system, patients entering the system in the future. And so we take the model and we register actually the model. So not just our hypotheses, but literally we can put the, you know, the weights that go into this model into a repository so it can't be changed. So it's locked up. And then for the first time, we have the prospective data and we evaluate how well the model works against the prospective data. And so we've done this with the clinical interviews across, well, it was 1437. I apologize. It's 1437 in blue here, and then it's about 900 actually in the evaluation phase. The age statistics, the demographics are correct, but not the end should be 900 there. And these were people that did a post-clinic visit interview, automated interview, with a microphone and video in our computerized system. And what we found, first of all, these are results for association with the PCL score using our development set. And we found that as baselines, first of all, just knowing their demographics, occupation, you know, there was an association of 0.15 that kind of forms a baseline. Then using language alone, we got 0.42, and putting the two together doesn't seem to help much. So given that these are different modalities, this is a pretty high association between a behavior and a psychological outcome. Now, then if we look at the prospective data, so that's now then saying, okay, we're going to evaluate against this data that the model was not trained, had never seen. And when we looked at that data, we were happy to see that the results remained slightly smaller associations, likely due to the fact that it's prospective, but we can talk in more detail about other ways information can leak into the standard AI training process. But overall, the results were still quite strong. And then if we look across the re-experiencing avoidance, the subscales of PCL, we got similar results with our best results here on the right. And we can see for all of the symptoms, we were able to have moderate to large associations between our predicted scores and their self-report assessed scores. And in particular, hyperarousal was had the highest accuracy. So as we're moving this forward, we're working more now in the multimodal domain, and for two types of use cases. So one is this prediction, you know, here assessing how accurate it is, you know, giving supplementing scores with these AI-based assessments, supplementing existing assessments. And that would be the prediction case, but we're also focused on an insight type of case. And here we see, for example, from language, we get topics automatically clustered words that are similar to each other that help us to understand what people are talking about that can be associated with their PCL scores. And here's some examples. of different topics that we see among this population, with talking about phone calls, talking about the event, the dust, talking about what they felt and what they're feeling, you know, kind of more daily activities, driving, cars, and relationships. And on the predictive side, we are bringing together these. This is, sorry for the somewhat complicated figure. This is kind of more of an AI style figure of a multimodal approach using a sequence model. Actually, that it's called a transformer, which is the same type of technique that's used in ChatGPT that can also be applied to doing sequence modeling, longitudinal modeling. And a lot of recent work, including some of our own, has suggested you get state-of-the-art results as compared to, if you know of like ARIMA models or other sorts of time series Markov models. These transformer-based sequence models tend to give even more accurate assessments. And our setup here has using multimodal data to be able to predict how someone outcomes in 1 day into the future, 7 days into the future, and then 6 months into the future. Okay, and so that's kind of an overview of a big picture of how these models work and what we're up to right now and some of our initial validation work. I don't know why this is automatically moving back forward and backward on its own. And now Whitney's going to talk about some more of our validation, incremental validity of some of our existing language-based assessments among some of our cohort.
Thank you. So like Andy said, I'm going to be sharing some results, and I'm actually be sharing from 2 studies. And they're unified because they kind of showcase the potential clinical and scientific value of 2 different behavioral markers obtained from AI that's relevant for PTSD. But first, I'm going to share results on the incremental validity of language-based assessments of psychopathology. So a big question that I've had when it comes to behavioral markers is whether they tell us anything different about a person's psychological functioning that we don't get from the methods that we're already using and the ones we've been using for decades. Because one potential application of language-based assessments is that it can be another clinical decision-making tool in a tool belt. So it's sort of augmenting humans that was mentioned before. So if language-based assessments can pick up on clinically meaningful information that clinicians miss or that people are unaware of, this opens up the possibilities of what we can really do with this technology. So in this study I'm going to show you, we tested this with a sort of head-to-head comparison of language-based assessments with our current standard assessments that are often used in research and clinical practice. So this was data collected from a subset of World Trade Center responders, about 1,300 of them, and they did a brief video recording. And in that video recording, they answered questions that you see here. Don't need to soak it all in, but just to give you a sense of the types of questions. So these prompts are designed to be sort of emotionally evocative. So both things, negative things like challenges, but positive things like nice things that happen to your family. And then from those videos, we used some of those pre-trained language models that Andy mentioned before to get assessments of psychopathology from those brief recordings. So specifically, we looked at language-based models of neuroticism, so low emotional stability, the PHQ-9, which is a measure of depression, and a language-based assessment of anxiety, or the GAD that was trained on the GAD-7. And the outcome we are interested in the study was mental health medication. So this is the number of psychiatric medication prescriptions that a responder filled during a given year. And this was obtained from their medical health records. And so for the analysis, what we want to see is whether these language-based assessments predicted medication use over and above self-reports or diagnoses made by clinicians. And so for each head-to-head comparison, we matched up the language-based assessment with a comparable self-report and a diagnosis. So neuroticism is like a general measure of distress, which we compared to self-report PTSD symptoms and a clinical diagnosis of PTSD. For depression, we compared that language-based assessment, PHQ-9, to the self-report version, to a clinical diagnosis of depression. And for anxiety, same sort of thing, language-based assessment of anxiety compared to the self-report version compared to a clinical diagnosis. Then we just use multiple regression models with each pair of these language-based assessment with either self-report or diagnosis as predictors. So we were testing, do language-based assessments predict medication use over and above self-report measures or over and above diagnoses? So what did we find? We'll start with the incremental validity of language-based neuroticism over self-report and diagnosis of PTSD. So what I'm going to show you here are incremental effects. So these are standardized betas, basically like a partial correlation. And what we see is that, yep, language-based assessments predict a small but significant variance in our outcome over and above those gold standard measures. Moving on to measures of depression, we see that, again, PHQ-9 predicts additional variance in medication use beyond the self-report version or clinical diagnosis. And same story for anxiety. Predicts the self-report and clinical diagnosis. So to kind of put it all together, the language-based assessments predicted medication use over and above our gold standard self-reports and diagnoses made by clinicians. And we also looked at whether language-based assessments have incremental validity in predicting another clinical outcome, the cost of annual mental health care services. So this is the amount of dollars that World Trade Center responders spent on mental health services. And the story is largely the same, with all language-based assessments predicting service utilization over self-reports and all but neuroticism out predicting clinical diagnoses. So in sum, I think this is pretty promising evidence that language-based assessments may provide us clinically useful information that we're not getting in our usual standard care. So this may mean that they can overcome some of the biases inherent to self-reports, and they may pick up on subtle cues that clinicians aren't aware of. And the prognostic power of language-based assessments here tells me that providers can potentially leverage these in practice to aid in clinical decision-making eventually. So we'll switch gears from language to a different behavioral marker now. We're going to look at facial expressions and how they can help us understand different emotion regulation processes in PTSD. So the emotion-related symptoms of PTSD are extremely heterogeneous. In the DSM, these are excerpts from the DSM, we see increased and decreased arousal, range of basic emotions in both subjective experiences and outward expressions of emotion. And generally, it's assumed that these symptoms reflect sort of emotional dysregulation. So some symptoms reflect hyper-expressivity in response to triggering day-to-day situations, whereas others reflect sort of emotional suppression to try and cope with distress. And all of these dynamic contextualized emotion processes may vary a lot, both from person to person and within the same person from day to day. But unfortunately, research to date provides pretty limited support for these hypothesized mechanisms. Most research has used self-reports, and the vast lion's share of this research finds that PTSD associates with negative affect. But self-reports don't really give us a full picture, because what this misses is the outward expression of emotion. And that's important because that reflects a person's reactions to trauma cues, and also nonverbals communicate to other people. So abnormalities in expression could affect social functioning. Now, there's a relatively smaller literature that looks at facial expressions in PTSD. And generally, this research takes two approaches. Either uses electromyography or EMG, which involves attaching electrodes to the face and detecting facial muscle movements. And what this research generally finds is kind of similar to self-reports, more intense negative affect expressions relate to PTSD. Now, there's another line of work, which we've kind of been talking about so far, which is getting that information from videos. And so back in the day, this was usually done with hand coding. So having raters look at the video and rate, kind of the moment expressions. But more recently, AI can really help make this process way more efficient. So we can get way bigger sample sizes and get a lot more information. But unfortunately, there's been really mixed results from this literature. Even though some studies have shown that PTSD can be predicted pretty well from facial expressions, when these studies try and find the specific facial expressions, there really no clear picture has emerged. So basically, we're getting the strong signal of negative affect associated with PTSD, and maybe facial expressions are related, but why haven't we been able to uncover these sort of diverse emotion-related symptoms that we see clinically? And there are at least 3 major limitations that have held back progress. Low ecological validity, so having electrodes on your face, it kind of interferes with emotional expression. And likewise, a lot of videos are taken in the lab during lab tasks, so we're not capturing people's reactions to daily life situations that really provoke and maintain PTSD. Second limitation is that these studies kind of ignore the heterogeneity in clinical presentation. So if we're trying to predict a PTSD diagnosis, or just comparing people with and without a diagnosis, it's kind of unrealistic probably to expect there to be a single emotional signature that defines all people with PTSD. And finally, most of these studies have been cross-sectional, but the temporal dynamics of expressions and symptoms is super important. So someone having a strong reaction to a trauma cue, then cope by suppressing those emotions, or someone who tends to get dysregulated and they stay dysregulated into the next day, these are all temporal dynamics that you can't get from a snapshot in the lab. So in this study, we address these limitations by studying emotion-related symptoms in real-life context as they unfold day to day, using methods that preserve rather than ignore heterogeneity in symptoms. So this is this was in PTSD STOP, which you heard about earlier, and this was 112 folks from that study, and they all have elevated PTSD. And each day in the study, this goes on for 90 days, they filled out a survey on their smartphone reporting their daily PTSD symptoms, and they also completed a 5-minute video diary talking about their day. And they were encouraged to talk about emotional topics and their symptoms. So again, here's kind of a list of some prompts we gave them that they could answer if they wanted to. They didn't have to answer all these, but just to give you a general sense of what we were asking for them to talk about in those videos. And then we use AI to detect facial expressions from the videos. So specifically, we use this software called Face Reader. And here's a screenshot of the Face Reader interface. So it detects those facial muscle movements automatically. Like I said, I used to do them back in the day, it hand coded, but now it just does it kind of in real time. And it uses a deep neural network to measure emotions expressed in each frame. And I was looking at happy, sad, scared, angry, surprised, and neutral expressions, as well as sort of like overall arousal or intensity of emotional expressions and head movement. And then for the analyses, we wanted to know, like, how are these expressions detected by AI track with self-reported PTSD symptoms? So to do that, I use this method called GIMME, which is a cute name. It stands for Group Iterative Multiple Model Estimation. And this estimates person-specific network models from time series data. So particularly for this study, I use GIMME to search all possible temporal associations between facial expressions and PTSD symptoms from day to day. So all those variables that you see there. And we are looking at all the possible contemporaneous paths. So how symptoms relate to increases or decreases in expressivity on a given day. And cross-lagged or predictive paths, which reflect how changes in facial expressions on one day lead to increases in next day PTSD symptoms and vice versa. And so I mentioned GIMME is a person-specific model. So what it does is it builds a separate model for each person, reflecting their unique patterning of symptoms and facial expressions over that 90 days. And this allows us to preserve the heterogeneity in people's symptom processes and then uncover commonalities between people in a sort of bottom-up data-driven way. So instead of finding behavioral markers that characterize all people with PTSD, the question is, are there dynamic processes that distinguish these subgroups of people with PTSD? And the short answer is yes. We found 6 paths that were significant for over 10% of the sample. This means these are symptom facial expression links that people had in common. So these first few I'm going to show you were just contemporaneous paths, so that consistent co-occurrence of facial expressions and symptoms on a given day. So for some subset of individuals, they have worse symptoms on days that their facial arousal or overall intensity of emotional expression changes from their usual levels. For some other people, the amount of head movement changes from their usual levels when they have worse symptoms than usual. For some other people, their levels of neutral expressions change from their usual levels when they have worse symptoms. And for some people, their scared expressions change when their symptoms worsen. So the co-occurrence of these expressions and symptoms suggest that these are behavioral markers of how people react when their symptoms are triggered by the day's events. And so we can think of facial expression intensity, neutral expressions, and head movement as sort of global physiological and emotional arousal, whereas fear expressions may be more reflecting an experience of threat. There are also two common predictive paths, so towards this idea of being finding behavioral markers that have prognostic power. For some people, changes in their levels of anger expressions predicted increases in symptoms the next day. And for some people, changes in neutral expressions from usual predicted increases in symptoms. And so these predictive paths suggest that a person's reaction to the day's events set off this sort of emotional cascade that makes them more vulnerable to experiencing symptoms the next day. Now, interestingly, for every single one of these paths, there were some people for whom the path was positive and some people for whom it was negative. So for people with a positive association, that means they become more emotionally expressive when they're experiencing symptoms. And for people with a negative association, that means they have dampened emotional expressions when experiencing symptoms. So I'm going to show you these results now, but the same results, but in a different way. So I'm going to plot each person's standing on those common paths. So those are the paths there on the y-axis, and I'm going to show you beta values, or basically correlations, on the x-axis. So here, each point represents the strength of that path for an individual, and the colored dots are the ones that are significant. And so we can see that everyone sort of falls along a continuum, with some people with a significantly positive association, so increased emotional expression, some people with significantly negative association, so dampened emotional expression. And importantly, here's the sample means, so which were all non-significant, meaning that if we didn't use idiographic models, we wouldn't have been able to detect these significant associations within subsets of the population. And that's maybe why there's been such mixed results and null findings in the literature, this sort of glossing over these subsets of people. And so since everyone falls somewhere along a continuum of these paths from significantly negative to positive, we can think of these processes or these paths as individual differences, and we can use them to create sort of an expressivity profile for each person that characterizes their daily emotional functioning. So I'll show you what I mean. Here's a profile for an individual person. So we'll say person number 52. And these are those 6 common paths that I showed you there on the y-axis. And again, the beta value or correlation on the other axis, and the asterisks on each of these are going to be significant. So this person tends to have more intense facial expressions, more neutral expressions, and more head movement than usual on days that their symptoms worsen. This suggests a sort of emotionally labile presentation. In contrast, we have participant 36, who has less intense facial expressions, more neutral expressions, and more scared expressions when their symptoms worsen, suggesting sort of an overall emotional dampening, but an uptick specifically in fearfulness. Participant 36 also tends to have worse symptoms days after they expressed more anger than usual. So maybe this participant fluctuates between having a threat response to trauma cues, so having this heightened fear and suppression of emotion at times, but at other times they react with anger, which only temporarily staves off their distress and then worsens the next day. Oops. So here's some other examples just to illustrate. The point being is that we can get way more personalized and clinically useful information about a person's problems when you think about their emotional dynamics. And these profiles hew more closely to emotion dysregulation dynamics we're interested in. So it may be able to eventually improve our ability to identify pathophysiological or behavioral mechanisms driving PTSD. So for example, we could test whether people with shared expressivity profiles have distinct patterns of neural activation when exposed to trauma cues in the lab. Could also be useful for therapists. So for example, if we have a patient whose expressivity is an early warning sign for them, they could benefit from increased insight into the social impact of their expressivity. So in sum, with this study, we established there's these consistent dynamic links that characterize the daily functioning of people with PTSD. And there's some evidence that facial expressions could be a behavioral marker that if detected early could help prevent symptoms before they even happen. So now I'm going to pass it back to Roman.
All right. Well, you guys have seen a lot. I'm sure it feels pretty overwhelming, and my task here is to go to 10,000, maybe on 30,000 feet, and try to piece this together as to what this means practically. But first, a quick review of where we are with PTSD STOP project that you've heard about again and again. But to recap, our first goal is to develop these behavioral markers, behavioral signatures, perhaps based on language, speech, that is vocal characteristics, facial expressions. As you can see, we are very well underway, and I'm optimistic that about a year from now, we'll have good models for modalities. The next step is prognostication, and that is taking information that we have on a given study participant, World Trade Center responder, for a couple of months, and then training model on that to predict are they at risk of escalation or maybe actually improvement tomorrow, a week from today, a month from today. So that we still waiting for sufficient data to begin, but we are planning this analysis very shortly. And finally, and very importantly, we are recruiting an additional population who are not responders to 9/11. They been traumatized in a variety of ways. So they're patients in the Stony Brook healthcare system with PTSD, but non-responders. And so we'll test how the models generalized to this population. They're completing the same protocol, but the models will not be trained in them. Okay, so on broader relations implications for the field. So this behavioral markers you've heard about, both from Andy and Whitney, they have potential to serve as objective markers of psychopathology. For the first time, we can actually assess behavior, observable behavior, and use this to inform care, specifically to improve detection of PTSD in settings where screening is not happening, such as primary care visits or follow-ups after ER visit for physical trauma, which may have had psychological components to it as well, to measure severity of PTSD beyond self-report, but also measure treatment response. So as I alluded to in the beginning, placebo response is a major problem for randomized clinical trials in PTSD, because placebo works surprisingly well, but perhaps it seems to work so well is because the outcomes are self-reported by patients. The participants in these trials want to be good participants, and if they report to the scientists that they're doing better, even if they're on placebo unbeknownst to them. In contrast, the objective measures might tell the real story and may show greater differentiation between treatment and placebo, active treatment and placebo, but that's entirely a conjecture at this point. What is a fact is that these efforts are not limited to PTSD. They're happening in other areas of psychopathology, in neurodegenerative disorders, in pain conditions. And of course, the idea is to integrate across different modalities. An analogy that helps me make sense of what we're doing is what has happened in auto manufacturing. This is becoming common in new factories to install cameras that as a final check, the manufactured car drives through at low speed, and this AI reviewing these images, if you can call it reviewing, can detect scratches, misassembled parts, low tire pressure, leaking oil, and a variety of other problems. This is also starting to be implemented by car rental agencies. So watch out for those. And this is possible to apply to our patients, or the amount of information about their health beyond PTSD that we can learn in video from them talking, from the characteristics of speech, is potentially great. So the way we can use it, let me give you a couple examples, is digital screening. So of course it starts with consent to evaluate a patient in this way. When given consent, we can use exam camera that's already in exam room and just forward the feed from the security camera to AI models to process information, audio, video channels for signs of possible disorders, such as mental disorders, the feedback that provider may receive at the end of the visit, or maybe partway through it. Of course, in the end, it will be up to provider to determine, is this credible? Does it require further assessment of the patient, or maybe referral? This may seem far-fetched, but in fact, we have technology already in the exam rooms that can do much of this. What I'm showing here, this blue box on the wall, is DAX. DAX is equipment developed by collaboration of Dragon, Diction, and Microsoft. And so they have sold these products to 200 healthcare systems as per their promotional materials, including such systems as Stanford Medical. And so what DAX does is that it's voice activated. So when patient and the doctor enter exam room, it starts recording and transcribing and filling a form of the basically encounter form or progress note based on that conversation. And then it mails this form, or just connects directly into Epic, that is electronic medical record system, where all provider needs to do after the visit is go in into Epic and edit the note. So that's already in many places will, perhaps not in your clinic, but likely will be coming in a few years. What we're talking about here, as far as detecting psychopathology, PTSD in our case, from at least voice and speech, is simply a software update to this type of device. Okay, another use case, this is without video, but another one is telemedicine. There, in this encounters over Zoom for healthcare or Microsoft Teams, contain all modalities, and the use is really taken off with the start of pandemic and has come down some, but still very common, especially in psychiatry, where more than half of visits, at least nationwide, are happening in this telehealth format. So processing this video along the lines of what you heard Andy and Whitney describe can give us those markers, and also can be fed into dynamic systems to predict next clinical moves. That's, of course, in the future. There are steps that we need to take to be able to achieve them. But a couple more about final slide about possible opportunities. So once we have forecasting models in hand, they can be used for short-term prognosis, such as passively monitor a patient, and when a model detects high risk of escalation, to deliver intervention. It could be good old phone call from the provider who got an alert that the patient seems agitated or talking about suicide, or whatever a model picked up, and provider response with outreach. Or it could be automated. This ecological monitoring intervention facilitated, enabled by patient's smartphone and the relevant app. Long-term prognosis would be about expectations for chronicity, probability of remission, expectations for impairment. We really weak in that right now in PTSD and a lot of mental health broadly. These models offer opportunities to improve prognosis dramatically. Treatment selection is another area we talked about. That remains a distant goal, but in principle solvable with AI as well. And then, so what kind of data do we need to really realize these opportunities? So you've heard us talk about recordings in the context of the clinic, in the context of this video diaries. They are all a bit contrived. They're special contexts that, like basically within a research context. What we need is data on routine clinical interactions. Let's say from telehealth. We are starting to gather them, but we certainly need large N. The larger the sample size available for training, the greater will be the accuracy of results in models. But in other words, building behavioral banks that combine the video, or at least phone calls, with information, clinical information such as what's available in TrialDB. To be frank, academics are good at training these models, not so much at delivering user-friendly products. This is where industry partnerships become essential, so they can make these models actually useful and effective in clinical settings. But we have to check, like once these products are delivered, do they offer incremental validity, as Whitney was showing? How do clinicians and patients react to them? Surveys of acceptability, feasibility, and hopefully there will be detectable improvement in patient outcomes. That also, of course, has to be checked. And finally, broad level conclusions that, just to recap, the challenge is that objective markers are missing entirely, that our ability to predict course and outcome is poor. AI techniques can potentially help dramatically, especially when applied over time to natural communications between patients and providers. And what this will allow us to deliver is more informative assessments, or maybe truly informative assessments of PTSD symptoms and prognosis. And this would arm both researchers and clinicians with better diagnostics. So how did we do? Did we pull off this musical chairs fine? What do you guys think?
Round of applause for our presenters today. Thank you very much, Dr. Kotov and Dr. Schwartz and Ms. Ringwald, for this very informative presentation.